Welcome to Oncology Watch. I'm Kathy Albert, a nurse practitioner here at Rocky Mountain Cancer Centers. Today, Dr. Mabel Mardones will be speaking about metastatic hormone receptor positive breast cancer. Dr. Mardones is a breast medical oncologist with Rocky Mountain Cancer Centers. She specializes in treating breast cancer with patients and those at high risk for the disease. Dr. Mardones is actively engaged in research and has presented her findings at national meetings, including the San Antonio Breast Cancer Symposium. Now I am going to turn it over to Dr. Mardones.
Okay, very well. Give me 1 second here. Okay, it's a great joy to be able to speak to all of you in regards to this important subject. Let me know if everything is going well, you all. You can hear me and see everything well? Okay. So what is the incidence of metastatic breast cancer? Well, we know today that there's about 40,000 women in the United States who unfortunately will die of their disease per year. We recognize that there are 3 different subtypes of breast cancer, which we all know today to be those that are estrogen positive, those that are either estrogen progesterone positive but have the HER2 protein expressed, or those that don't have any of those 3 markers, and those are traditionally called triple negative breast cancer. We know that the vast majority of breast cancer incidence today is that of which is estrogen driven. As we can see there, 60 to 70%. And although metastatic breast cancer is unlikely to be cured, there's been dramatic improvements in the therapies today. And we also know that this is ever changing so fast, and that is obviously a very positive thing. So the goals of therapy are to prolong life, improve survival, increase the time from which our patients remain on certain active and tolerable regimens. They are obviously not to cure the disease, it's to palliate the disease. In other words, it's to really reduce the volume of disease and the burden of symptoms that come about from this disease. And the goal is to maintain therapy until either there's intolerable side effects, which we obviously hope that we don't have to reach, and we work with our patients, or until the disease progresses. In other words, we have resistance to some of the therapies that we have, and we need to move forward with this next line of therapy. So what are our tools within our toolbox that we have? Well, we have different ways of reducing estrogen. We have ways to deplete the estrogen directly. We do this in postmenopausal women by blocking a certain enzyme, and this is traditionally called, as a lot of us understand in breast cancer world already, as the prevention hormone blocker pills. These are called aromatase inhibitors. In premenopausal women, we can also reduce the volume of estrogen that's being produced in the main source or factory of the estrogen, and that is in the ovary. And also we have a way to not only reduce the volume of estrogen that exists, but rather to block the estrogen that, or block it from acting upon the tissues, that is the breast or other sites, of course, if it exists in their places. So a picture to really highlight what I'm addressing today is really, as you see here, in either premenopausal or postmenopausal women, and where we block that production. Traditionally, with the premenopausal women, we would offer them a shot version, which is more commonly known as Lupron, although there exist others. And this is essentially blocking the hormonal directional signaling from the pituitary gland to the ovary, and we can diminish that, but it doesn't take the place of still blocking estrogen from other sources. And that's where in a postmenopausal women, we prevent that conversion. As you can see there, anastrozole acting in that direct inhibition, and then tamoxifen, fulvestrant, and other agents blocking the estrogen from acting upon those tissues. Here you see a picture of how tamoxifen sits on top of that estrogen receptor, which prevents that estrogen from acting upon the tissues and converting, or essentially signaling the brain of that cell to do what it needs to do. In this case, obviously, we're trying to prevent excessive growth. As you can see there at the top, though, testosterone does play a role in some of this as well, and I think that's something to really reckon with. And you'll see mentioned in the end of our talk how we are in an effort to try to understand as to whether we could also block androgens or testosterone alongside estrogen, and how we could potentially get additional mileage from that sense. And so what we also understand, though, is that there's additional targets that we can target beyond the estrogen molecule in this case. And there are three broad stroking classes for which that are currently mainstay therapy in metastatic hormone-positive breast cancer, as you can see detailed there. We're going to first talk about the CDK4/6 inhibitors, which have really revolutionized the care of metastatic breast cancer. We also have the other class of agents, which are called Mtor inhibitors, and also PI3K inhibitors, which have really come into the limelight here over the last year. And we know that by doing this, we can mechanistically enhance the benefits of estrogen blocker therapy. So the intent of this diagram here is to really try to simplify how CDK4/6 inhibitors work. But essentially, I think what the best way to understand this is that cancer tends to capitalize on any machinery that we have in our body to divide, grow, and develop new cells, whether normal or cancer cells in this case. And so we have what's called a cell cycle that exists in all cells. And if we can somehow block that cycle from happening, or essentially decrease the amount of time spent in that cycle for these cancer cells, we know that there's an interplay between estrogen and these and the cell cycle, that if we can arrest the cells right at the first start of that division, arresting them but not killing them, which is different than chemotherapy, and that's important to understand. We're essentially just slowing the process through that division, that essentially if we do that, we can increase the chances of causing cell death in tumors, in this case, breast cancer cells. And so these agents came about and were approved first, leading with palbociclib or Ibrance in 2015. So the first studies, the first in-class drug was Ibrance, followed by abemaciclib or Verzenio in 2016, and then followed by Kisqali, which is also called ribociclib, in 2017. So we'll talk about these agents here in a few, but essentially what I'd like to highlight is that all of these drugs have had substantial activity, not only in those patients who are diagnosed at their very first time with metastatic disease, or what we call first line, but also in the second line, meaning those patients who have progressed generally on what has been considered standard of care, which is the hormone blockers alone. We know that we can add a CDK4/6 inhibitor and improve outcomes. And what I think is important is that across all studies, across all agents, there's been a reduction of about 40% in decreasing the risk of progression in our patients. And as of recent, both ribociclib and abemaciclib have actually shown a survival benefit. So again, that's really the hard, fast endpoint that all of us want to achieve with our therapies. We don't just want to prolong life, rather prolong life and improve symptoms, but we really want our patients to live longer. And I think hormone-positive breast cancer, metastatic hormone-positive breast cancer, is really a testament of what we can achieve together with the research that's being done. And so as you can see here, this is really to highlight the numbers that we're seeing across our trials. So in those patients who are endocrine sensitive, so this means these patients who have a recurrence of their breast cancer after generally 12 months after being on a hormone blocker therapy, or many, many years after, we see a doubling, essentially, of progression-free survival. So an average of about 14 months with hormone blockers alone in the old days, and with combinations, we're seeing a 24 to 25-month improvement. In the second line, that means patients who, again, have already progressed through another therapy or are resistant to endocrine therapy, meaning they had metastatic disease during the time that they are on the hormone preventative medicines, or within that 12-month time frame. That time is less, but as you can see there, it is still doubled. So we're going from about 5 months to 11 months, some other studies 9 to 16 months. So it is unequivocally a positive response to these agents. And so where are we using these drugs again? To highlight again, these are patients who either are diagnosed in the first line setting, these are endocrine sensitive, first event in combination, so that's important. We don't use them in isolation. We use them in combination with hormone blockers, and this is now considered standard of care therapy. We also use it in the second line setting after someone already has progressed on the first line. We generally will change the hormone blocker after that, generally with another agent such as fulvestrant, which we'll talk about how that works at a little later time frame. What we don't know today, which is a question in research at the moment, is there is no current data to suggest that one agent is superior to another. So how we pick one agent out of the three that I've discussed is really dependent on the safety profile of these drugs, how we select those agents. There's a couple other nuances that obviously we could go into in regards to, do we treat a premenopausal women with a different drug? And that's something that we could certainly get into at a later time frame. But there is no evidence, I think this is really the point that I wanted to make, that once someone has already been exposed to this whole class of drugs, whether at the beginning or in the second line setting, there really is no data to say that switching the class of drugs, meaning going from Ibrance to abemaciclib, is really going to provide patients any additive benefit. However, the whole breast oncology community does have some signals towards potentially an improvement in that being the case. But currently today, as of October of 2020, there is no data to support that switching to another is beneficial. But stay tuned for further data as time moves forward. We'll pause here to talk about a slightly different setting than that of metastatic breast cancer, but has some implications to this whole entire class of drugs. And this is really more to say that there's large studies going on at the very moment that are either finished accruing and maturing, or those that are still in the process of accruing, that are enrolling patients who are high risk. And how do you define high risk? Well, all three of the studies defined it in a different way. Some included patients who were grade 3, some who had high proliferative rates, meaning proliferation, meaning that these tumors are growing fast, generally over a 20% marker, or those who are node positive, and they define the positivity in slightly different ways. Some, up to 2 to 3 positive lymph nodes. Some really wanted the highest risk patients, included patients that had 4 or more positive lymph nodes. But essentially, all 3 of these studies are accruing. We are getting some positive signals as we speak, particularly last month in one of our big meetings in Europe, that suggested that these patients may, in fact, derive some benefit, particularly the highest risk groups. And so then that's going to leave us as an entire community to help our patients understand, well, who are exactly those patients? And we need to certainly balance out some of the side effects, which is a really important point to then talk about now. So what are the side effects of these class of drugs? So the first is, we'll mention that the schedules of these drugs are slightly different. Palbociclib and ribociclib, mentioned first in the graph, are given every day, 3 weeks at a time, 1 week off. Abemaciclib is different in that drug is given twice a day instead of once a day, and it is given daily with no interruption break. This is just the way the studies have been designed. By and large, the more common side effects are hematologic. That means what I call paper side effects, or something that we can see in the white blood cells, red blood cells, or platelets. By far, the more common one is a low white blood cell count, referenced here as neutropenia. And as you can see here, let's talk a little bit about grade, because you're going to see this word grade mentioned in the rest of the follow-up slides. So what grade means is that we have a very specific way, the way studies are done in general, and how we assess the severity of side effects. So in this case of neutropenia, globally speaking, anything that is grade 1 or grade 2 is something that does not merit any intervention, and by and large does not cause any consequence to our patients, meaning that side effect is not going to cause you to necessarily feel poorly or to have an interruption in your treatment. But grade 3s and 4s are generally something that we as your providers need to intervene. We need to do something about that. In the case of neutropenia, we probably need to hold the therapy. We need to reduce the dose of the therapy. But the important thing to note here is that you'll see that any grade is the incidence of in palbociclib and ribociclib is actually in the 50s to 80%. So you'll see that number decline. But the most important thing, especially in a pandemic that we're all living with today, is what is a consequence in terms of risk to our patients? Will you have an increased risk of side effects? Will you have an increased risk of infection? And as you can see there, the rates of actually having a febrile or a fever or an infection as a result of this number is actually less than 2%. So that's a reassuring thing about these agents, that although it is truly causing something that we see on the back end and it causes us to be concerned, it is a totally different class of drugs than chemotherapy, and the risks of infections are truly very low with these class of drugs. There are also side effects that are not hematology, meaning reds, whites, and platelet changes. Those generally are mostly grade 1 or 2. So again, no real consequence, no real intervention. Our patients may feel it, but they can continue to live their normal lives that they wish to live. So, because all drugs that are given orally have to be processed through your GI tract and your stomach and your small bowel. There's always risks of nausea, vomiting. We know that these drugs can contribute to fatigue and feeling tired. As you can see there, the word alopecia means thinning of the hair or hair loss. That incidence is there. It is mostly grade 1. So grade 1 meaning that there's hair thinning, but never hair loss. Truly hair loss, for example, with chemotherapy would be something like grade 3, where there is clearly something that women need to hide, or if they wish to, they can use a wig if they want to not have that be seen. Diarrhea is something that we do see more so with the third class of the medicines that I've mentioned so far, which is abemaciclib. But as you can see there, the degree of diarrhea that really needs intervention is really by and large low at less than 10%. These follow-up slides are certainly not to go into extensive detail, but I basically have given you all an idea of the more severe intervention type side effects that could happen. But there's an overriding concept here that all of these numbers, as you see, are low. Where I'll stop a little bit is in that abemaciclib can increase your creatinine level, which makes it seem as though your renal function is not entirely normal. This is not as a result of a lack of function of kidney, but rather just an issue of an enzyme that's not being properly utilized. So the function remains normal, but we do see a rise in the creatinine, and it generally happens fairly early. With ribociclib, which is Quisquali, that's one of the unique medicines out of the 3 that can increase some of the electrical wiring in your heart, which certainly poses some concerns for all of us. And so that is a medicine that we do monitor your electrocardiogram or EKG for the first 2 months, and we try to optimize your potassium and magnesium to lessen that risk. Abemaciclib or Verzenio does have a slightly increased risk of clotting. So as you can see, I'm mentioning things that may help us decide as your provider which drug may be right for you, which drug may not be maybe not the best medicine for you, dependent on your prior histories, and certainly family history as well, particularly if you have an increased risk of clotting nonetheless. And then this new class, side effect or toxicity is called an inflammation of your lungs, which is called pneumonitis. This has come about as of recent with the increased utilization of these drugs over the last few years. As you can see there, though, any grade is only 1%. So again, it's really for us as your providers to be very cognizant and aware. And at the very onset of any pulmonary symptoms, such as cough or shortness of breath, we really ought to be looking and doing a scan and interrupting the treatment, because this is generally a reversible side effect if the treatment is stopped. So how do we manage some of these side effects? Well, by and large, we really tend to either hold treatments, interrupt treatment, dose-reduced treatments, and in the case of neutropenia, we know that this is not permanent. None of the things that we're talking about are permanent. So in other words, these side effects recover generally over a period of 1 to 2 weeks. For the non-whites, reds, and platelet side effects, so diarrhea, liver tests, very similar concepts. This is really more to mention the fact that if we do see liver test elevations, this is something that generally comes a bit later, so it generally does not come about when during the first 2 to 4 weeks. We see it a little delayed into the 60 and 70-day time frame, and it is generally with ribociclib and abemaciclib. So if someone has pre-existing liver condition, for example, like fatty liver, and they already have an elevated liver test to begin with before you start therapy, we may want to choose palbociclib, because it doesn't carry that potential side effect, or it doesn't confuse us. But again, nothing remains permanent in this case. So the summary in regards to this entire class of drugs is that this is a huge advancement in the care of metastatic breast cancer patients. We now have not only clear signals that this improves and doubles the time frame of progression, so the time from the time of diagnosis to the time in which patients need the next line of treatment, but we also know that they improve survival. The side effects, as really mentioned recently, they are really favorable. Our patients can coexist with these medications. They can continue to live normal, healthy lives, active lifestyles. If patients have side effects, they are moderate and really manageable. Quality of life is really, studies have shown this, that the quality of life as opposed to other options that patients may have really is improved with these class of drugs. Again, really nice that they're oral medications. You just take 2 pills and you know that you're getting that benefit. The side effects or the adverse events are different, and how do we choose that is really a joint decision together. We know that diarrhea is a little bit more common with abemaciclib, and there's a little bit more incidence of neutropenia with the palbociclib and ribociclib. So on to the second class of agents that we have to treat metastatic hormone-positive breast cancer. So this is a class of drugs that we know we have one agent in this class, although many others have been in the development and there's others in the pipeline that are forthcoming. But this one has been around since 2012, so we have a lot of experience with this medication. It's called everolimus, or also called Afinitor. So what this class of drugs is that the Mtor pathway is basically a kinase, and a kinase is a type of protein that we have in our body. Kinases, they help all cells, both healthy and cancer cells, so that they get energy that they need. So when these kinases, through these pathways, you can see there, don't act normally or are overactive in the case of cancer, because as I mentioned before, all cancers, breast cancer obviously likes to capitalize on any machinery, and it likes to go and act uninhibitedly and make new cells very rapidly. So again, when they're overactive, they can help certain breast cancers grow. So these Mtor inhibitors work by interfering with this kinase and stopping the cancer cells from getting the energy that they need to grow. So again, the same overriding concept exists here that it did with the first class of agents. We don't use these drugs in isolation, meaning that they work best or in combination or synergistically or best when used with hormone blockers. So this class is approved with a aromatase inhibitor called exemestane. This was the very first combination that was studied in this study, which is called the Bolero study. And as you can see here, this class of drugs improves progression-free survival by, it essentially doubles it. So it increases by about 4 to 6%. So, 3 months, for example, versus 7 months. So there's a clear improvement that the combination certainly made sense. But this class of medicines has also been studied with 2 other hormone blockers. Tamoxifen, which we previously mentioned, which is a selective estrogen receptor modulator, sits on top of the estrogen receptor, and fulvestrant, which is the only SERD, and SERD means selective estrogen receptor degrader. So instead of sitting on the receptor, it not only sits on the receptor, but it actually degrades that receptor, so that there really is unequivocally no way for any more activity to go through that pathway. So again, they have shown an improvement in progression-free survival, clinical benefit rate, and time to progression. There are also ongoing studies looking at the combination of everolimus with other forms of endocrine therapy and also CDK4/6 inhibitors, interestingly. So this is really not to be a very overwhelming slide, but really more to indicate that there are really combinations going on with exemestane and ribociclib, also exemestane and chemotherapy drugs. There's different combinations, sometimes some studies in the first-line setting, others after progression on a non-steroidal inhibitor. There's also combinations of 3 different drugs, maybe CDK4/6 inhibitor, exemestane, and a hormone blocker. So again, we're really in the process of getting a renewed utilization of these agents in different settings. So stay tuned for follow-up data in this regard. So what are the side effects of this class of drugs? Well, as you'll see here, also very manageable. And I think that through the last 8 years now, we've learned quite a bit in regards to how do we handle these side effects, how do we make adjustments in the therapy early on. And so as you can see here, the first side effect is mouth sore. So that's the medical term for mouth sores. That we knew at the beginning was something that we saw in upwards of 8% to 10% of our patients. That number no longer looks that way. So that is now a lot less, well below probably 2%, because we now have a preventative mouthwash that we know can really improve this issue. We know that red blood cell numbers can decline. That's anemia. The transaminitis is the elevation in the liver test that can happen, again, fully reversible when identified and the drug is stopped. We know that this particular pathway that I previously saw, that you'll see referenced again, has to do with glucose management and control. So when we block this pathway, we can see a rise in glucose levels, can cause some shortness of breath. So again, the same concept that we talked about with the other class of drugs, it can cause some inflammation in your lungs. And so again, that side effect is far and few between, but important for us to identify, and fatigue. By far, in this study that was just referenced, the two more common side effects or reasons for the drug to have been discontinued as it was being studied was either inflammation of the lung or the mouth sores. As I mentioned, the mouth sores have really been diminished quite a bit, so we can really maintain patients on a therapy that really works quite well with our new interventions. And then again, education is really important for your medical oncologist. If you're using these drugs on a day-to-day basis and have many patients, you have more experience and are apt to recognize that potential side effect. The last class of drugs I'll mention is the PI3K inhibitor. So this one is the very newest kid on the block, if you will. This was just approved last spring in May of 2019. And it was approved in combination with a hormone blocker, in this case fulvestrant, which is the oral SERD that I mentioned. Is also called alpelisib or Piqray. And again, it's for advanced metastatic hormone-positive breast cancer that has progressed on initial hormone therapy already. So we know that this pathway has been a pathway that we have wanted to block or work on for a long time. Why? Because it's actually the more commonly mutated gene in hormone-positive breast cancer. So approximately 40% of patients with estrogen positive, there's a typo there, estrogen positive, not HER2 positive, estrogen positive, which is the topic of our discussion today, have this mutation. So you're seeing this picture again, because again, it's a very important pathway, very important process we wish to block. So when we have this mutation, we have an increased risk of tumor growth, and overall the prognosis for patients that carry this is generally not as good as those who don't. And so these blocking of this or using this medication helps block that resistance that happens with estrogen expression. And how do we know whether patients have that mutation? We can do it in two ways. We can either test the blood at the time of your original diagnosis or at any time in the follow-up. So it generally is a mutation that if you have it at the beginning, it's likely there to stay. So it's generally not acquired through more pressure or treatment, or you can go to the tissue, the actual biopsy that originally confirmed your diagnosis to test for that. And so this study was called SOLAR-1, and it is still maturing, meaning we're still gathering information from this data. But the original presentation said that, again, there's the same concept as before, that progression-free survival improves, generally from 5 months to 11 months. And so that was a win for these class of medications. And again, let's go back to that slide to really emphasize that this improvement was actually only seen, and you'll see that in that when you look at it a little closer, the very top diagram there says the benefit is in those patients who are actually mutated, means that have that particular mutation. Those that did not have that mutation, referenced in the diagram below that, you see no difference, no division of the curves. So in other words, we can't give that medication to someone who does not have that mutation because it won't work. So what are the side effects? So again, anything orally, we've talked about this diarrhea, we know that nausea, mouth sores are a risk, but as you see there, 2.5%. So when you see that percentage crossed by a slash, the other is in those patients who weren't on that medication. Fatigue, vomiting, and then I think the things I've really highlighted are two things that actually are, as you see there in numbers, more common. So 20% rate of grade 3. These are all grade 3. That means a side effect that needs intervention, that we need to do something about. 20% incidence of rash and about 40% incidence of high glucose levels. So again, this is not a side effect that is irreversible, meaning we don't give you diabetes irreversibly and forever after you've been exposed to these medications. You may have to be on diabetes oral medications throughout this time. Very rarely do we ever need to use insulin. But for example, metformin, being the more common oral medicine to treat high blood sugar, can be used, and again, will generally be used only during the time you're on this medication to treat your cancer. Lastly, let's talk about some new up-and-coming therapies in estrogen-positive breast cancer. I think all of us that treat this disease, and our patients are eternal optimists in regards to what is up ahead, and I think there's reason to be. It is justified to be excited about the future that's to come. I think our prognosis for our patients is a lot better than ever before, and these new class of drugs show a lot of promise. So I'll stop to really talk about only two, but as you can see there, as mentioned before, by blocking androgens or testosterone and estrogen together, we may be getting synergistic or additive benefits, so that those studies are ongoing. The other point I'll highlight before going into some details on the two bolded agents is the fact that we are routinely testing our patients not only in once they've been diagnosed with metastatic disease, but we're testing them now more broadly and more commonly in the front end, meaning when you've first been diagnosed with an early stage breast cancer, we want to know, do you have a genetic predisposition that could make a difference for not only your family, but as you can see here, there are therapies now that are given in patients who are BRCA1 or 2 mutated that have made a tremendous difference. And this is now a new tool within our armamentarium to treat estrogen positive metastatic disease or metastatic triple negative disease, which are really by and large the two more common subtypes of breast cancer that exist in BRCA1 and 2 mutated patients. So that's important. If you have not had genetic testing of your normal cells, this must be done because this is, again, a very important therapy. And then there's other oral drugs that are in development that are constantly being studied, and we recognize are in the process, this being one of them, HDAC inhibitors, and we won't go into those details. So first, let's talk about oral SERDs, which are the selective estrogen receptor degraders, which you have heard me say already. We have a drug like that already, which is called Faslodex. That's the injection form that's given once a month, generally speaking. And then we'll talk about what are drug antibody conjugates. So first, oral SERDs. Around 30% of patients with metastatic breast cancer achieve tumor regression. Now, meaning they'll have a shrinkage of their tumor seen on imaging. About 20% though won't have shrinkage, but they'll have stable disease, meaning there's no progression, there's no new lesions. So resistant mechanisms of why patients progress on other classes of drugs like the ones we've mentioned, why is it that things progress? Well, the answer is that, well, it's complicated, there's many. But one of them is the acquisition of mutations within the actual receptor, that is the gene. So these are what called ESR1 mutations. And if you have this mutation, it allows your tumor to survive and proliferate, interestingly, without dependent on estrogen. So you can block estrogen. You can do that, as we saw shown before, with aromatase inhibitors. You can decrease the actual substrate or the volume of estrogen that exists. But in this case, some of these cancer cells, they say, well, I don't really care if there's enough estrogen around. I'm still going to provide growth through that receptor. And again, one of the reasons is the development of this mutation. So although tamoxifen or aromatase inhibitors decrease or can prevent, usually there's almost unequivocally progression very soon thereafter after these mutations have been found. And these can be found in up to 30% of all of our patients with metastatic breast cancer who've already been treated with one form of hormone blocker already, because again, it's something that develops as you get treated with your disease. And we know that if you have this, your prognosis is slightly inferior. So there's been an effort to try to develop agents that can more effectively block that continued process or growth through that receptor. And in order to do that, if it doesn't want estrogen, then you got to degrade it. Degrade it meaning you got to destroy that receptor. So fulvestrant has some limitations. It's a good drug. It does wonders for a lot of our patients, and there's clearly a subgroup of our patients who can be on that medicine for years. But it's a shot, and by virtue of that being a shot, you can't get maximal medication on board when it's given that way, because you can't inject a large volume of that agent in the subcutaneous tissue. It actually takes a while for that drug to build its levels up and actually do what it needs to do, which is, again, prevent estrogen from flowing through that receptor. So we want to be able to reduce that engagement. So by having agents that are oral, which will build up faster in your blood, one, the ease of convenience of being able to be given orally at home is great, and having a better efficacy at that receptor is really the goal of these therapies. And lo and behold, as you'll see, these are the chemical compositions of these drugs. We are now in a flurry of new medications in this whole class. Just to give you an idea, there's about 14 total in development. These are by far the 5 that are the most advanced in clinical trials. We are participating as a Rocky Mountain Cancer Centers in various studies. I should really pause and make that point clear, that almost all of the drugs that you see mentioned that have been approved dating back to 2012 with everolimus and the medicines, the CDK4/6 inhibitors, the CDK4/6 inhibitors in the high-risk setting, we've been enrolled, and we have had all of those studies available for our patients. So we feel very proud to be part of an organization that is really in cutting edge, bringing our patients the newest and greatest studies, and our patients who are enrolling into the studies are the reasons why we now get to talk about these new therapies today. So this is, we have currently a study right now that's looking at one of these oral SERDs, the one mentioned at the bottom of the slide, which is called elacestrant. This medication we're using in this study in patients who have progressed on 2 other lines of therapy, including CDK4/6 inhibitors. We now have a study that's about to open up in the next few weeks, because there's a flurry of new studies that are being constantly opened and closed, accruing, etc. There's a new one coming on board with this oral class of hormone blockers, SERDs, that's going to be used in combination with CDK4/6 inhibitors in patients who have first diagnosed with their breast cancer. So instead of using an aromatase inhibitor, if this could be a better way of blocking estrogen, might this be the way to try to get our patients to live longer, have more survival, and increasing the time of progression? We don't know that, but that's currently being studied. And I think the good news about these medicines is that they're very, very tolerable, at least the beginnings of these studies that we all know about. They cause maybe some mild nausea, maybe some vomiting, nothing that can't be addressed or prevented with our traditional preventative medications. Can cause some slowing of your heart rate, nothing that has you feeling poorly, just something that we see. And then some of these agents, we've been noting some visual changes, some blurriness, but nothing that remains permanent. But again, the data is forthcoming. The last class of drugs I'd like to mention is something that I think we are all, as breast medical oncologists, extremely excited about, because we are already using these medications. This is the good news. So now we're just taking these medications and now extrapolating them and trying to put them into the armamentarium of use into our estrogen positive. But for example, this first drug is called sacituzumab govitecan, also called Trodelvy, and also famtrastuzumab deruxtecan, which is called Enhertu, are both drugs that are actually approved in the first in triple-negative breast cancer, just approved within the year. And the second is a drug that, as you see mentioned, trastuzumab. All of you who are familiar with breast cancer know that that drug is used in HER2-positive breast cancer. So we are already using these medicines, but now they're being studied in estrogen-positive breast cancer, And the studies are quite promising. Just to name the first, the Trovelti, there's a study that's called the Tropic study that actually just closed, but I enrolled many patients into the study that, again, was a way to bring this drug to our patients who have progressed on hormone blockers. So in other words, and now have become estrogen resistant, and now they are on chemotherapy. This is a way of delivering chemotherapy in a very, very smart way. So what do I mean by that? Well, Trovelti was approved for triple negative in April of this year, and in HER2 in December of 2019. So basically, in the short and skinny, or like simplifying the way this works, is that all cancer cells, in this case breast cancer cells, have some identifiers on the outside of their cancer cells. They have a personality, they have a protein. We've talked about the way that they have receptors for estrogen, but they don't only have estrogen receptors. They have many other ways of making themselves known that they are a breast cancer cell. So in this case, obviously, you can develop or engineer an antibody. An antibody is something that you have in your own body that helps attack, so it's part of your immunity, that helps attack viruses, bacteria, etc. So and so in this case, we want to target something specific to your cancer cell. But attached to that antibody, which is essentially just a vessel, it's a vessel to carry chemotherapy. So attached to it is a linker, and attached to the linker is a chemotherapy agent. In the case of TROP2, it's SN38, and in the case of HER2 is a different agent. And so what do we do with this is essentially, once the antibody attaches to the cancer cell, it eats up that antibody, and once it's eaten up, then it releases the chemotherapy. It releases the chemotherapy agent into the cell, and it kills that given cell. So it's a way of, again, releasing chemotherapy in a very targeted way so as to minimize side effects to the normal healthy cells. So it's a very, very effective way, and I think we're extremely excited about the use of these medications in many, many different settings, not only in breast cancer, but other cancers today. And with that, I'd like to end this discussion. Obviously, there could be many, many other things said on this topic, but I hope that this provides you all an overview of what is being utilized currently as standard of care, what are potentially some of the side effects, and what is coming our way, and how there is an abundance of reason to be extremely excited about the future for our metastatic hormone-positive breast cancer patients today. And with that, I'd like to thank you for your time. We'll take questions now.
Thank you, Dr. Mardones. That was very insightful, lots of great information. I think you'd agree that we are blessed to be in a day and an age when we've got a plethora of options for our patients in the metastatic setting. So one question that we have is, how do you determine which agent is best for the patient sitting in front of you? How do you determine the sequence? And within that question, if you could also answer genetic sequencing and molecular profiling, the individualized care that has come from the advancement in technologies has allowed us to individualize treatment and our diagnosis and therapies for our patients. So how do you sequence?
I'll address this. And I'll address the second one first, Kathy, which is, how do you test, or how do you sequence genes, and why do we do that? So I'll first speak, because that pours into how do we decide on treatment. So the first is that when someone's diagnosed with metastatic disease, we actually want to know two things. One, what is happening with your normal cells? In other words, do you have a gene, as I previously alluded to, more commonly known as BRCA1 and 2, but there are others, that is the reason why you developed your breast cancer to begin with. And that has direct implications for therapy. So in other words, if you have BRCA1 and 2, you now have options, whether on study or off study now, to have these PARP inhibitors, which are also oral drugs. So that's one way or reason to test your normal. So sequencing your normal genes, and we do that with a blood test, simple blood test. Our genetic counselors do that. We can do this as your medical oncologist. But the second piece is what Kathy is, I think, alluding to, which is how do you sequence the cancer cells itself. And this has to do with the fact that when you have cancer in your liver or your bones, more commonly with hormone-positive breast cancer, you are in a constant state of shedding circulating tumor DNA. So tumor has obviously DNA, as all of our body cells have, and it's being shed into your bloodstream. So we can actually do a blood test, a simple blood test like a regular blood draw, in a more complicated way, send it out for different platforms or different companies that do these types of testing. And there's new companies all the time coming into this arena because it's a really important need. And then it'll test many, many different genes, often in the order of, never less than 50, 70, 80 genes at a time. But this is, again, of the cancer cells themselves. And so if we find a particular mutation, right? So in let's say we do a circulating tumor analysis and we have an ESR1 mutation. We talked about that mutation already. We said that decreases the odds that patient will react well or do well with an aromatase inhibitor, because it doesn't really care if we decrease the estrogen. It's still going to activate that pathway through that receptor because it's mutated, it's active, it's overactive. So that may make us, as your medical oncologist, want to choose a therapy that is not an aromatase inhibitor. Instead, we may want to partner, if you're firstly diagnosed, we may want to partner it with Faslodex, or we may, instead of changing the hormone blocker to tamoxifen or something else of that nature, we may want to change it to Faslodex because that may be better. Or in this case of the new therapies that are up and coming, we may want to do an oral SERD, which is one of the newer agents, which I am certain will be approved in the next few years to come. So that's one way of doing that. And it is considered, I would say, standard of care today to have these tests done. That can be done either when you're firstly diagnosed or at any time in between. So in other words, if you progressed on this first choice of medication and things grew on the scan, then you may want to have that information to make a better decision for what's used next. And then it becomes quite important as you're moving forward to more treatments, or you're using or utilizing more treatments, because that may get you into a very specific trial that may be testing a specific mutation that, had you not known that existed in your tumors or in your blood, you would have never been able to have the next up and coming therapy that may be exactly what you as an individual need, because your tumor carries this specific gene. So that's getting to Kathy's point, which is we want to be as personalized as possible, to not treat something globally, but to be as specific or tailored to you. So personalized cancer care is really the wave of the current state of affairs and of the future. So that's where we would test those things. What other considerations is the second question do we have in regards to how do we choose? Well, we choose based on side effects, as you saw there. What pre-exists coming into your diagnosis of breast cancer or metastatic breast cancer? We take that into consideration. A big piece of how we make decisions is how do we think, based on our experiences using these drugs in other individuals, how do we think you will tolerate the treatment? Because remember, the goals are two, and they generally need to blend. They need to be one and the same. We don't just want to give you therapy that prolongs life at the expense of quality. So it has to be quality and duration of your life. Hopefully they're in the same direction. So if we think that one medication may not do well for you, that diarrhea is a problem because you have inflammatory bowel syndrome or irritable bowel syndrome and you struggle with that already, for example, I may not want to give you abemaciclib, which carries some risk of diarrhea more so than the others. So we'll choose it based on that. Your age matters, how functional you are, how your organs are functioning leading up to this diagnosis. All of those things are taken into consideration. So I think those are some of the answers to that question.
Thank you so much, Dr. Mardones. That was a wonderful presentation. Thank you for being a part of our team. We so appreciate your dedication, your compassion. You're such a great asset to our team, and so glad you joined us. But thanks again for the great information.
Thank you, Kathy. And we, again, thank you so much for listening. We would be happy to see you at Rocky Mountain Cancer Centers. And any questions, go to our website. That's a great place to start. Thank you again.